Welcome, everyone. I'd like to welcome you all to our monthly HSPN webinar for Ontario Health Teams. Really pleased that everyone is here today. If we could go to the next slide, just let everybody know to come into the chat. Make sure you click on the chat box that says to everyone, not only to hosts and panelists, and please introduce yourself. I look forward to hearing about who's joining us today. Let us know who you are and where you're joining us from. Hopefully people have access to the chat because, oh, there we go. Melissa from Thrive Health. Welcome, Melissa. Which means that everybody else can be joining in now. Great. Tanya McKee from the District of Muskoka. Alexander from the Ministry of Health. Heather from CMHA. Patrick from the Peterborough OHT. Welcome. And now they're coming in. Abigail from Woodstock. Jim from Welland. Claire from Ontario Health. Diane from Great River, welcome. From all corners of the province, people will be joining us today, and sometimes we have people from across Canada and even internationally. And I think today's topic is a very interesting one for everybody who's joining us. I am speaking to you today from the University of Toronto, and for thousands of years, this land has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. And today, the meeting place is still home to many Indigenous peoples from across Turtle Island. I'm very grateful to have the opportunity to work on this land and contemplating all of its many uses over the past centuries and time immemorial, particularly as we come towards our Day of Reconciliation, which is less than a week away for us to bear contemplation on where we're at. And I know around our table at home, we're having many conversations about how many of the recommendations and why our progress has been so slow on addressing so many needs with our Indigenous communities across Canada. So I'm thinking about the ways that we can continue to advance and particularly to act upon the recommendations. I'd like to know, I see people are still coming in, Dean Valentine from Toronto and the Patient Family Council there, Aaron from Trillium, Carrie from Temiskaming, welcome from all over the province. We are going to go to a poll and just have a sense. Go to the next slide. Let's go to the poll first, and then we'll come back to these. So 2 more ahead, 1 more. There. Let's see if you have joined us previously. So we can launch this poll now and see if it's the first time you have joined us or whether you have participated previously. Have you joined us previously? We did have a little bit of a preview when people were signing up and signing in, but I haven't checked recently, and I'm not entirely sure today amongst the over 100 people that have joined us today. Is this your first time or have you joined us previously? Okay, it's starting to slow down a little bit. Maybe we can share that out, and I can see we have brought a new topic to individuals, and it has attracted a new audience. What interesting, we have 60% have participated previously and 40%, this is your first time coming to our webinar that we've been hosting since 2019. So it's a special event for us and for you to have so many new people joining us today. We can take that down now and maybe we can go back 2 slides and just orient people to where we are in this overall program right now. So we are on a little bit of a series right now around this Learning Health System Action Framework. We introduced this back in April of this year, and then through May, June, and July, we went through the first 3 of what we call gears in this, the engine of the center of the learning health system, and they spoke to using analytics and population insights, evidence synthesis, and in July we had patient and caregiver provide a co-design. Today we move our way down to the left corner of implementation. So go to the next slide. Let's talk a little bit about what do we mean by implementation. And it's all about implementation today. So this is just what the framework talks about it and how it talks about implementation in the learning health system context. And so it's systematically converting research findings and other evidence-based practices into routine and what we like to think of as sticky practices, things that will be sustained over time, that enhance the quality and impact services. So some of the questions that we think OHTs and anybody out there working in change management, quality improvement, implementation, that you should be thinking about how to stage the implementation, what change management methods and communication channels can be used. And we're going to learn a lot about that today. How can behavioral motivation be built? Why aren't people already doing the things that we think are good ideas? And how to train people in new ways of working and new ways of receiving care as well. And so there are many different elements of the health system: quality improvement teams, leaders, project management, informatics, change management, more training. Many elements come to bear. And so we're going to have a bit of a kickoff today on some of these and get some tools and practices that you can all implement. And we have a standout lineup. Just before we get to our speakers today and that lineup, I'm going to welcome Kaylee to come. And I think Kaylee, so we have to advance, I think, 3. And Kaylee's going to let everybody know about upcoming activities around our community of practice. Kaylee.
Hi, thanks, Walter. So looking at some of the names, there's some familiar faces who might know about the community of practice, but I guess there is a lot of new people here today. And I wanted to highlight this community of practice just because one of our upcoming sessions really does build off this learning healthcare system series. So we have an evaluation, community of practice called Evaluation and Performance Measurements for OHT. And this is really for people working on evaluation and performance measurement in OHTs, with the idea that we want to be sharing experiences across OHTs. So members would have access to a shared evaluation and some measurement resources. And we also connect monthly on a teleconference. And that's the second Tuesday of the month over lunchtime. And some of our topics have included using IDS, evaluating patient engagement, or survey methods. Then next slide. Like I said, we have a couple upcoming sessions. The one in October would be might be of particular interest to this audience. So Dr. Victor Rentes will present on assessing learning health system capabilities, a self-assessment tool for continuous learning. And so if you are interested in becoming a learning health system and using a tool to assess, or just want to hear about it, that would be a great session for you to attend. And then also just highlighting our next session on November, which is more an analyst cafe. So really looking at sharing experiences and challenges at the analyst level. And you can check the shared space for registration on that after our next meeting if you're interested. And I believe Trisha has popped the link, the registration link in the chat. So if you want to do that now or save that for later, you're welcome to. And then just highlighting for those who haven't joined and would like to join, I'll get Trisha to pop another link in the chat box, but really you can check out the Ontario OHT shared space page. It's hosted by Rise, and there's a sign up or sign in option there. And then there's various communities of practice or groups there. And so you could search for evaluation and find ours and sign up as a member. And we welcome all those who are working on and interested in evaluating OHTs to join.
Wonderful. Thank you very, very much, Kaylee, for that update. So people, please do feel welcome. This is a very active Ontario Health Team. Pat Camp, welcome. OHT stands for Ontario Health Teams. And I'll try and pay attention to acronyms that sometimes I think we just get very, very used to using. Today, I just really want to be able to welcome Dr. Tina Fahim, who's a scientist with the Knowledge Translation Program at St. Michael's Hospital. She is the lead for the Team for Implementation, Evaluation, and Sustainability, which is called TIES at St. Mike's. She has her PhD from McMaster University, Health Evidence and Impact, did a postdoctoral fellowship at Johns Hopkins University, and she still retains a position there. She's also a member of the Canadian Institutes for Health Research's Governing Council. So she oversees what kind of research we we should and shouldn't be doing. Jeanette Cooper, with her as well, is also on the TIES team, and she has a Master of Science in Epidemiology from the Ontario Veterinary College at the University of Guelph, and now she has joined the KT program with Dr. Fahim. And I know that I did my postdoctoral fellowship supervised by someone who had their PhD in epidemiology from the same college. So there's a tie there for us, Jeanette. Marjorie Hammond is the Regional Geriatric Program Clinical Nurse Specialist for Geriatrics with the internal consultation team at St. Michael's Hospital, and brings today the specific context around which we're going to learn about implementation science. And that is around pain management for people who've had a hip fracture. She's a graduate of Practicing Knowledge Translation Program at St. Michael's Hospital and has an extensive experience in nursing for degrees. We're from McMaster and then a master's from Charles Sturt University in New South Wales, Australia. So she's also got experience from around the world. These three individuals are going to lead us through what implementation is, how to do it in real world sense. So we're going to really learn about that. And I think we're going to want to know what the people who are participating today, what your examples are. So I think we're going to join in and have some chat around what you're trying to implement so we can build that into the conversation a little bit. I'm going to do just one poll before we turn it over to this amazing team. And that is to get a ground of what your knowledge is about implementation science. So let us know if you are very familiar. You could talk a lot about it all day long. You have a good awareness, whether you have some or limited awareness of implementation science, or if you really have no idea. And I'll say that I have worked my way up. I think I'm probably about a 2 now. Over the past number of years, I would not have really known what it was when I started my career. Yeah, so let's see. We have, people are very fast on this one, so I think we could share that back out. Lovely. And so we have some limited awareness of implementation science from just about half of our participants. And then there are about 10% who can talk a lot. I expect you to be in the chat contributing to this conversation as well. And please put your questions in around implementation science for those people who have less awareness. Lovely. I am now going to turn it over. I think, Tina, you're going to start us off. Welcome to the Ontario Health Team webinar, and thank you so much for coming and sharing with us today.
Thank you so much for having us. We're really excited to be with you and to speak about our favorite thing, which is implementation science. So we'll jump right into the agenda. Next slide, please. So just to give you an overview of what we hope to cover in the next hour or so, I'll start speaking a little bit about knowledge translation and implementation. I'll then hand it over to Marjorie, who will present a really practical example of how we use some of these methods to do implementation work in kind of real world settings. And then Jeanette will round out this session by giving you a series of practical tools and resources that hopefully will be helpful to inform your own work. Next slide. So just a little bit of context on why I think it's important to talk about implementation. So some of you may remember a commentary that came out of the Canadian Medical Association Journal. And in this commentary, the author said that Canada is essentially a country of perpetual pilot projects. And what they were arguing in this commentary is that the way that we fund research results in a lot of pilots that don't actually make their way into sustained programs that we could see outcomes at the patient or at the system level. And this kind of method of funding projects that are really kind of stopping at the pilot and not thinking about long-term impacts and sustainability is actually doing a disservice to our health system. So about 5 years after that, the Lancet Journal published a series of articles around research waste, and they described what's called a leaky pipeline of research. And in this series of articles, they were essentially saying that the way that we're doing research is not necessarily the most efficient way. So we're asking questions that might not be important to our knowledge users, might not be important to our patients, and actually missing the mark on what some of those health system priorities are. We're not looking at what research has already been done and trying to add to it, resulting in a lot of duplicated work and research waste. And when we are doing research, we are not always reporting exactly what it is we're doing, and we're unable to kind of learn from each other's successes and failures. And so what's happening kind of in the way that we're funding research and the way that we're conducting research is resulting in this leaky pipeline of research waste that's not letting us realize kind of the return on investment in research in terms of patient and systems outcomes. Next slide, please. So knowledge translation was seen as a potential solution to this problem. And so knowledge translation, or KT, there's a lot of kind of different terms floating around. When I talk about knowledge translation, I'm using the Canadian Institutes of Health Research definition, which talks about a dynamic and iterative process. And within knowledge translation, it includes both the knowledge synthesis, so thinking about the quality of the evidence, the dissemination of that evidence, and then what's kind of the feature of our talk today, the implementation of that knowledge. So essentially, it's about putting knowledge into action at all levels of the health system in order to improve health. And along the way, we want to be doing what's called integrated knowledge translation, which is essentially doing research with the people who use it. And so these people are called knowledge users, and they can range from patients, caregivers, all different types of clinicians, policymakers, administrative personnel, etc. And we know that when we actually work with knowledge users early on, it results in research that's more relevant, more applicable, has greater likelihood for implementation success, and then greater likelihood to have impact at that patient and the health system level. Next slide, please. And so the knowledge to action model, this is a planned action model that's rooted in theory, and we could use this to really kind of map out our steps of implementation. And the nice thing about the knowledge to action model, why I like it so much and why I think it works nicely with kind of learning health system framework, is that right at the core of the model, it emphasizes the need to have quality evidence. And so again, thinking about that research waste pipeline, we want to make sure that what we're implementing is actually rooted in evidence. And if that evidence is not there, that we're proceeding with caution and really kind of testing out our strategies before we kind of do any large scale implementation. So we can advance the slides a couple times. Yeah, so next slide. So at the core there is that funnel. We can move to the next slide. And so the funnel essentially kind of talks us through all the phases of doing research. So at the very top is knowledge inquiry. So these are our individual randomized trials, our observational studies. These are our kind of bread and butter research studies. But it's rare that we're going to change our practice, especially at a large scale, based on the results of a single study. Instead, we want to really take time to synthesize the body of evidence around a specific topic. So we move into our next step of the funnel, which is around knowledge synthesis. So at this stage, we're doing systematic reviews, meta-analyses to appraise the overall body of evidence and to say, okay, we have confidence that the evidence is solid here and we can move on to implementation, or maybe we need to do a bit more research before any kind of broad scale implementation. And the last step of the funnel is really that bridge between thinking about evidence synthesis, dissemination, and then implementation, because we know that when we publish a systematic review or a meta-analysis, that won't really translate into uptake. So we have to think about the different types of tools and resources that can make our knowledge accessible to knowledge users so they could actually implement it. And so in that final funnel, we're creating things like decision aids, guidelines, policy briefs, infographics, so really tangible products that tell people exactly what it is that we want them to do. So with that in mind, we can advance one more. There's two questions here. So what topic or focus or population are you aiming to improve care for? And specifically, have you identified any evidence-based practices that you want to implement at your hospital or in your Ontario Health team? And feel free to throw your answers in the chat and I'll read them out as they come in. Heart failure and COPD, other evidence-based practices, palliative care, diabetes care, spontaneous breathing trials in ICU, traumatic brain injury, hip fracture, mental health and addictions, aging in place. Fantastic. Primary care, surgical care. Fantastic. So the thing that I really, oh, staff health and well-being. So this is fantastic. And what I hope will be helpful in this session is the nice thing about these tools is it's really a toolkit. And so regardless of what the evidence-based practice is, these are kind of a series of steps that you can take in order to support the implementation of all of these evidence-based practices. And the fun thing about my job and what I feel very privileged to do is get to work on a range of all different types of studies and different topics using these tools, many of which were highlighted in the chat, which is really great. Excellent. Okay, so we'll try to kind of bring up these examples as we go, and then at the end, also happy to take specific questions and to speak about your projects if helpful. All right, so oh, and I see a comment from Walter that maybe I'll pause and call out here too, is what sources are you using to identify your evidence-based practices? So for example, are these practices coming from a guideline, from a review, from a quality health standard? Yeah, Health Quality Ontario, clinical practice guidelines, HQO standards. Great, excellent. HSPN, excellent. Okay. Perfect. So we'll keep going here and keep those practices in mind as we kind of think through the action cycle. So again, the first step is to really think through what evidence do we have? What is the practice we want to implement? And once we've sorted that, we can then move to the outer cycle of the knowledge to action model, which takes us through the specific steps to implementation. Next slide. And so there are four key questions we can keep in mind when we're working through that action cycle. So the first question is, what is the evidence-based practice? So what specifically do we want people to be implementing? The second step is who needs to do what differently. So implementation requires people to change their behavior, to change their practice. So who are all these different actors that are going to need to change their practice to facilitate the implementation? Next is why would these people change their practice or not? And then finally, how can we support the practice change, or how do we facilitate the implementation of the what? And so I'm going to be using an example from a project called MOVES. MOVES stands for the Mobilization of Vulnerable Elders. And this was a project that was led by Dr. Sharon Strauss, who's the director of our program. So essentially, the MOVES team found a series of systematic reviews, including a high quality Cochrane review, that showed that when older adults are admitted to hospital, the first thing that happens is that they're put to bed. And in that time, we start to see a lot of negative outcomes. So we see increased hospital length of stay, decreased cognitive function, decreased muscle capacity, and that a lot of these outcomes can actually be prevented if we mobilize older adults early on and we mobilize them often. And so the goal of the MOVE study was to support the implementation of a mobilization program for older adults across Ontario hospitals. And so the first step, if we're thinking about our key questions, is thinking about, well, what exactly do we want people to do? And so when we kind of when we talk about these methods, I often say if you're stuck in an elevator with somebody and you have 10 seconds to tell them what it is you want them to do, what are the specific practices that you're going to tell them? So you're going to move beyond your goal. You know, it's not just I want to mobilize older adults or I want to improve this outcome. We want to kind of drill down to the specific practices that when those elevator doors open, that clinician, that patient knows exactly what it is that they need to be doing. And that process is really defining our what using evidence. So in our MOVE study, there were three specific practices that we wanted to see implemented. The first is that we wanted patients to be assessed for mobility within 24 hours of being admitted to hospital. The second is that we wanted patients mobilized at least 3 times a day. And the third is that we wanted the mobilization to be progressive and scaled to that patient's ability. So once we've defined our what, we then want to think about all the different actors that are involved. So who's going to need to change their practice in order to get this implementation into routine care. So, of course, that includes physicians, nurses, occupational and physiotherapists, but it also includes patients. It includes caregivers who are now being asked to walk when they're admitted to hospital. So when we map out all of our who's, all of our actors, that really helps us identify our knowledge users. And then we can work with these groups of people to figure out what their needs are and to co-create our implementation plan with them. Next slide. So the next step is to think about, well, why would these people change or not change their practice? And this step of really interrogating the why is really kind of the backbone to implementation science. And we want to make sure that we are not assuming that we know the reasons why change will or will not happen. And rather, we're using a systematic approach and a theory rooted approach to think about all the different reasons at the individual level, organizational level, contextual level, why behavior may change or not. And that's important for a number of reasons. First of all, it helps us make sure that we are not incorrectly making assumptions about, maybe it's a knowledge issue, maybe it's a capacity issue. We can be more assured that we're not skipping potential barriers and facilitators to change, but it also prevents us from contributing to this research waste. So now we're not going to be suggesting strategies that maybe aren't actually targeting the barriers that exist. We're not assuming that certain interventions are going to work when we haven't kind of done the legwork. Next slide. So when we're thinking about why, we're really thinking about barriers and facilitators. Why would people change their practice? Why would they mobilize patients? Why would they not mobilize patients? And here we can really look to the implementation science literature to give us a series of practical determinant frameworks and tools to help us systematically think through those barriers and facilitators. And Jeanette will present a number of these to you as kind of easy to use tools and worksheets at the end of the session. Next slide. So this is an example of a theory that's linked to some of the commonly used frameworks in implementation science. And essentially this theory, it's called the COM-B, which stands for Capability, Opportunity, and Motivation of Behavior. And essentially what the COM-B argues is that you need to have the capability to change, the opportunity to change, and the motivation to change. And if one of those components is missing, it's unlikely that your behavior change is going to be realized. So thinking about the practices that you listed in the chat, what do you think some of the barriers to implementation might be related to your evidence-based practice? Is it capability? Are people lacking the knowledge or the skills to implement the practice? Is it the opportunity? Do people not have the time? Does the environment or the physical space, is it not conducive to implementation of the practice? Are there potential social factors, cultural norms that are impacting opportunities? Or is it related to motivation? Do people maybe not think that this is very important? Or do they think that, there might be negative harms if they implement the practice? Or as Sarah highlighted, spot on, is it a combination of the three, which is often the case? So thinking about that, we can move to the next slide, and I'll invite you to just throw in the chat your ideas of what potential barriers that you might experience might be when it comes to implementation of your specific practices. And you can present this in a couple of ways. We could talk about the COM-B, capability, opportunity, motivation, or you could just say people don't have the time, people don't want to do it, people have too much on their plates. So throw those in the chat and we'll kind of read them out. Political will, lack of resources, buy-in, not enough staff, funding issues, stigma, time, leadership capacity, not enough time, opportunity, tough to get buy-in. People are still burnt out from the last 5 years. Absolutely. Fragmented healthcare system. People don't see value. Not a strong relative advantage. So what I'm seeing here already, we could see that barriers could exist at a number of levels, right? They could exist because, as Walter highlighted, maybe people don't really see value in the specific practice. They might be barriers at the individual level. These physicians are over capacity. Nurses don't have, room on their plate to take on another intervention. Patients don't see the value of the implementation. It could be at the organizational level. Patrick talked about tough to get buy-in. Jillian spoke about people are still burnt out. Steve talked about unionized environments, and it could also be kind of at that systems level, at the country level. So we really want to think about all these potential barriers and make sure that we're addressing them in a way that is really rooted in theory. Great, next slide. So these are some examples of barriers that came out of our study. And when we did our barriers and facilitators assessment, our why, we actually talked to all the different knowledge users. So that's a really important piece of implementation is we don't just want to speak to the clinicians. We want to make sure that the intervention works for the clinicians, works for the patients, maybe works for the policymakers. And we really want to make sure we've spoken to all of our who's. And so these are examples from our clinician interviews, and they kind of highlight the range of barriers that were present with mobilization. The first barrier came from a physician, and this person said, "Well, it's not my job to move the patients. That's what the physiotherapists do." So we could advance the slides. So in this case, they felt that this was not within their professional role of practice. It was not in their kind of job description, and so that related to motivation. And they didn't feel that this was something that they were really eager to do. The next barrier, somebody said, "Well, I'm afraid that if I get patients moving, that they're going to fall. And now, we have fractures to deal with." So in this case, the person felt worried about what are the consequences of implementation. So this is actually going to result in a harm. And I don't feel that I have the skills to mobilize people safely. So again, we were able to kind of categorize that using theoretical frameworks and then mapping them back to theory. And I know in implementation, we often really focus on the barriers. It's just as important to use this process to think through the facilitators. And these are the levers that we can use to our advantage in order to support the implementation. So one facilitator that came up in our interviews is people said, "Well, once I started encouraging patients to mobilize, many did it on their own, and it was really great to see those changes happen so quickly." And so in this case, we saw these positive reinforcements almost immediately, which really motivated the clinicians to continue mobilizing patients. Next slide. So using this process of again thinking about all the reasons why people would change or not gets us one step closer to now picking the strategies that will match those barriers and will leverage those facilitators. And again, Jeanette will show you some practical examples of tools that can help you with that matching process. And so in our study, next slide. Um, so sorry. So in terms of the strategies that we could use, how we're going to bring about the change, these are methods or techniques that could be used to enhance the adoption of a practice. And there's really an art and a science to picking these strategies and operationalizing them. There's a quote by, oh, sorry, we'll go back. There's a quote by Richard Grohl in the BMJ, and he says that evidence-based medicine needs to be complemented by evidence-based implementation. And so when we're picking these strategies, there's kind of a few things we want to keep in mind. First is we want to make sure that they're rooted in theory, that they're actually going to tap into those behavioral components we identified. Second, we want to use the body of implementation science to operationalize these in the most meaningful way. For example, if we pick an audit and feedback intervention, there's a whole wealth of literature out there in implementation science about what is the most effective way to implement an audit and feedback intervention. And we want to be using that evidence to inform our practice. At the same time, recognizing that we want to work with our knowledge users to make sure that things make sense in their context. So again, we don't want to fully design something only to take it to people and realize it doesn't work. We want to co-create and think about sustainability really at the onset. Next slide. So these are examples of different knowledge translation strategies, implementation strategies, many of which I'm sure look familiar and you may have used in your own setting. And if you have, feel free to kind of throw in the chat the different strategies that you may have tried and your experience with them. But these include things like audit and feedback, communities of practice, educational materials, and local opinion leaders. So again, it's not that these are necessarily, novel strategies that you may not have seen before. The key here is making sure that we're picking the strategies that match the barriers and that we're operationalizing these in a way that aligns with evidence and a way that aligns with user needs. So I'll pause here just to invite people to put in the chat if they've tried any of these strategies. I think using data to get buy-in is critical. Agree, Patrick. And I think that's the really nice thing about kind of thinking about the learning health system model, thinking about the KTA model, is really centering data and evidence in terms of what is it that we're currently doing and what is happening in our setting versus what should we be doing and what does the evidence say. Reminders through electronic medical decision support tools, public release of performance data through regional report cards. So audit and feedback, reminders. Any other strategies used? I see that this series is also using community of practice, which is great. Carrie highlighted a really important barrier here. Integrating implementation science, absolutely. Patient family-centered engagement, absolutely. Having a champion. Fantastic. So the great thing about this and what I love to see coming out of the chat is, using these strategies is important, but we have to do that in partnership with our knowledge users. So that integrated knowledge translation, that co-creation is really, really critical here and promotes buy-in, promotes implementation success. Excellent. Okay, next slide. So in terms of the strategies that we created for the mobilization program, next slide, we actually had a multi-pronged strategy, which is often what we do in implementation science. And so for our setting, we had, next slide, we had educational sessions for clinicians. We had educational materials, some that were patient facing, some that were clinician facing. We used reminders, and we also used mobility champions on the floor who really promoted the uptake of the intervention. Next slide. And so just to kind of summarize the key points here is that the most important thing is that our implementation strategies must match the barriers. And we could use implementation science frameworks to help us kind of think through all of those whys and then to pick strategies that will correspond to those barriers and facilitators. And what we want to avoid is the iliaca phenomenon, or what's coined by Martin Eccles as it seemed like a good idea at the time, right? And so very often we have these really great ideas for an app, for a webinar, for an educational session, and only to realize that maybe we're actually not addressing the behavioral domain where the key critical barrier is. And maybe it's actually not about knowledge. Maybe we need to actually restructure the workflow or the process. And so taking that time to really think about that why and that how will again help our implementation success, but also reduce the likelihood of us contributing to that research waste. And so I'll make a plug kind of in advance of your next session, which I think is focused on evaluation, is along the way, we really want to be evaluating iteratively to think about what happened and why. And we want to evaluate the quality of our strategy. So how well did we implement these strategies? And if we implemented them well, did we start to see signals in behavior changing? And if we started to see those signals, did that actually result in changes in practice? And if so, did those changes result in patient and system level outcomes? And so the next slide just gives us an example of thinking about kind of an evaluation map for our study. So we started by thinking about, okay, how well did we implement our program? So how many clinicians participated in the educational sessions? How well were our reminders implemented? Did they resonate with people? And if this was done well, did we see improvements in knowledge about mobilization and skills? Were people more aware about why it's important to mobilize older adults? And did they have increased intention to mobilize older adults? And if all of that was kind of tracking, did we then see actual translated improvements in our mobilization rates that then resulted in decreases in cognitive decline, loss of muscle function, length of stay, and increase in patient satisfaction? And the important thing about evaluation, again, I kind of keep harping on this, but it really avoids our research waste and our effort waste. So we don't want to be 3 years into an implementation program, a QI program, only to realize I actually didn't see changes in mobilization. early on, if we're evaluating, hey, nobody's actually showing up to the education sessions, or people don't really seem to like the audit and feedback, we can iteratively revise and change our strategies. And then that gives us confidence if things are going well, that we should start to see signals at that next stage. Are we seeing improvements in knowledge and skills? And if not, do we again need to go back to our implementation and revise something? So again, implementation is very iterative, it's very dynamic, and the evaluation really helps us make sure we're on track so that we can either go back and change what we're doing or feel confident that we're on track for implementation success and to explain to others why implementation was successful or not. All right, so with that, I'm going to hand it over to Marjorie, who's going to talk us through a case study using some of these methods.
Okay, hello, welcome. Okay, we can take the first slide. That'd be great. So what I'm going to talk about is actually all the whys, the who, the what, where of related to our study. And our study was using implementation science to promote the use of fascial iliacal blocks in hip fracture care. Next slide. So we're talking about the what and the why. Now we know that FI blocks are a part of one of the 15 quality standards for hip fracture care, and that when we did an audit, we realized we were suboptimal performers with respect to this quality standard. And of course, we wanted to deliver the highest quality of care and to reinforce and foster a culture of quality of care. So we look to, and I'm just going to advance the slide just a smidgen. There we go. I'll take that out. Oh, go back, please. Okay. And that in the health quality standard, we focused on quality standard number 3, multimodal analgesia, which is considering the use of non-opioids, such as an NSAID, and of course, the providing peripheral nerve blocks in fracture to help manage fracture hip pain. Next slide. Okay, and why would we consider that as an intervention and an important intervention? We know that most hip fractures occur in older adults. More than 30% are greater or equal to 85 years old. And that with an aging population, we have a medically more complex population to care for. And older adults are more vulnerable to adverse events, and 1 in 5 experience a complication. And we have a 1-year mortality rate of greater than 25% in our elder population. That hip fracture pain is very severe, and that pain control in the elderly population or anybody with a hip fracture is paramount. Opiates are known to be associated with considerable many adverse events, including delirium, respiratory depression, constipation, pneumonia, and ileus. Next slide, please. Next. Okay. So we looked at using this knowledge to action wheel. Our no to gap then was the health quality Ontario standard for the management of hip fracture pain. And then it was standard number 3, multimodal approach, including fascial iliac blocks or peripheral nerve blocks. And an audit showed that we were suboptimal in our performance rates for the delivery of fascial iliac blocks at St. Michael's Hospital. And although we had a policy existed, it didn't ensure that actual access to this intervention for patients. Our project goals were to increase the number of patients greater than the age of 50 presenting to the emergency department at St. Michael's Hospital and the delivery of a fascial iliac block within 12 hours of a diagnosis. We wanted to improve our patient outcomes through effective interprofessional collaboration and comprehensive engagement of our stakeholder groups across the transitions and and care for our fractured hip patients, and utilize rigor during our implementation endeavors, and settled on using implementation science methodology to enhance practice change. Next slide, please. Okay. So in our endeavors, we interviewed 25 staff members and coming from the various departments, including the emergency department, orthopedics, anesthesia, and geriatrics. We did 5 patient caregiver dyad interviews, and we had site observations in the ED anesthesia, our regional room. This is where peripheral nerve blocks are administered, and our orthopedic units. Interview guides were developed using the CIFR tool. And so you can select your key constructs of interest for both populations, and they were modified for staff surveys and for our patient and caregiver interviews. And we use a framework approach regarded for barriers and facilitator analysis. And then we mapped and developed evidence-based intervention strategies from that data. Next slide, please. Okay. Example of some of the barriers and were a lack of standard process to coordinate the delivery of the blocks with the regional room. Another barrier was that the delivery of the fascial iliac block is reliant on the healthcare provider initiative and memory. There was no formal process for them to do this. And from a patient and caregiver perspective, there was difficulty for them to make healthcare decisions while experiencing the severity of a hip fracture pain. Next slide, please. Okay. Here's an overview of the number of barriers and facilitators that we, barriers particularly that we observed. And 10 was the highest, and that had to do with the actual clinical environment. And then 8 barriers were related to creating and the distribution of education materials, and 8 with identifying and use local opinion leaders, 5 with around using champions, and 2 audit and to provide feedback dimension, and of course prepare patients to be active participants, and then train staff on F1 block procedures, and then 1 block around the notion of changing and mandating change. Next slide, please. Okay, so our number 1 priority was the environment. It had 10 barriers. We had no pre-existing standard clinical pathway, and it became evident that this needed to occur first, as a first priority. So now when a patient comes to the emergency department and is diagnosed with a hip fracture, at any point in time, if the ED physician is trained, they can provide a fascial iliac block. And in order to improve that, we created a list of trained MDs for the RNs to also support and advocate for their patients. They actually didn't know who could and would do blocks in the emergency department. And we ensured that those kits, F1 block kits, and the medication were available within the emergency department. An alternative pathway is that after hours, the orthopedic surgeons, once they are informed that this patient has a hip fracture, they can actually call the acute pain service. And the anesthetist can actually administer the block either in the room or defer to the operating room if it's after hours. Also, during the weekdays, the pathway is quite clear that every day we get a notification from the fracture liaison coordinator that sends an email first thing in the morning, 7:30, to the pain service and then to geriatrics. Previously, it was usually geriatrics because we already had an automatic referral process for hip fractures and geriatrics. And we would call the anesthetists and they didn't have a room. And we would say, this patient really needs a block. And so now they are informed well in advance of this patient. And we now have a dedicated space in the regional room for them to perform this. And again, can do it either in the regional room or in the operating room as well. Next slide, please. Okay. Create and distribute our educational materials to staff. So we created it, and then of course we took it back to the users and got their feedback and kept modifying this until we got the tools appropriate and based on their feedback for staff. And next slide. Okay. And we also did the same thing with patients and caregivers. And you can see the difference in making sure that what they felt they needed, the information they needed to make informed decisions about this information was appropriate for them. Next slide. All right. So how did we empower and motivate and educate? Well, we engaged our patient family education specialist, especially with the patient caregiver tool, and she made sure that we had appropriate language. And with that tool, we engaged our ED ortho unit educators to be part of that process and more champions, engaged patient family tools, and we engaged the patient and family in the tool development. We engaged RN staff in tool development. We engaged the managers and IT with regarding the standard operating procedures and electronic health record order set development, and which led to patient tool empowers the EDRNs to discuss F1 blocks with the patients, and that the geriatric CNS, myself, educates actually the ortho educators on the unit, because some people actually may not be in the emergency department. They may get actually transitioned to the floor. And we wanted that staff and the educators to also advocate. So now we have a list of trained ED physicians to facilitate the block delivery in the emergency department and advocacy on the RN's part. We have onboarding tools and resources created for the EDRNs and a process created for delivering the F1 blocks after hours and on weekends. Next slide, please. Okay, so we looked at all of those strategies that came out of mapping of our barriers facilitators to intervention strategies. It was environmental restructuring. We implemented that. The education got implemented. Our enablement, we implemented persuasion, which was to collect and analyze and distribute our performance data on fascial iliac block, and of course, training staff on peripheral nerve blocks procedures. Thank you. Next slide. All right. So our outcomes. So what did we say? We did see an increase in fascial iliac block from 48 to 65%. The time to F1 block was also it was decreased from 1.63 to 0.81. We saw a decrease in delirium from 43 to 34%. We did not see necessarily a change in opioid use or pneumonia. And with pneumonia, it could be skewed because we were at the beginning of COVID when we were kind of looking at data and so forth. So we had COVID, and so that might have factored into some of those that outcome measure. Okay, thank you. So the message is, don't drop the ball. Once you've done these things, you can't take your eye off the ball. You need to constantly reinforce to motivate. You need to identify those champions and educate the new learners. We often think that if you don't you do a one-off and that sticks, but people are moving. We particularly know that nurses change, they come and go, and other people come and go. And so we need to routinely also reinforce what best practice is and be those champions. Continuous quality improvement. And so you need to continually monitor and evaluate and modify those gaps in order to sustain your implementation. Thank you.
Thanks so much, Marjorie, for doing that great talk on the FI block project. That it's been helpful for people to hear a little bit about a real world project using some of these methods. I'm gonna kind of keep it going with the real world and talk about some of the tools that you can use to help support implementations, how to actually do some of this in practice. There's a lot of tools and resources to support, but before I jump into some of the introducing you to some of them, I thought I would ask, what tools are people currently using to help them support implementation efforts? Type your answer in the chat and I'll call some of them out that people are using. As Walter said, or are you not using any tools? Let's see some education sessions and information fairs. Lily's mentioning that data is useful for frontline staff. Lots of education materials, some Teams channels. And so lots of implementation strategies, which is great. So, yeah, so I see a CFIR framework. It's great. And Carrie uses frameworks to identify strategies. Yeah, so some of those things like the CFIR framework and other frameworks are some of the kind of tools that I'm going to talk about, some of those things that will help you identify what some of those strategies might be best to use. So I will move to our next slide if that's all right. Great. Yeah, so the first tool that I'm going to talk about is one that we developed here at the Knowledge Translation Program. This is something that was led by Tina and a number of other staff in our program. And this is a workbook that's designed to take you through that action cycle portion of the knowledge to action cycle. So the workbook has 5 main steps. So it wants to take you through identifying your what, identifying your who, help you understand why people will or will not do what you want them to, identify what strategies you can use for your implementation, and then help you plan for how you can evaluate and sustain. So this is a whole workbook. It's published open access and you can access it online. And we're also going to provide it, and Walter and team will post it on the HSPM website for you as well. So you can grab it easily there. If we can go to the next slide, I'll show you, this is one of my favorite figures from this workbook. And it shows you kind of all of the different, well, not all, some of, because there are many, but some of our favorite tools for doing implementation and working on these different steps of the action cycle. So, for example, you can see when we're trying to figure out why would somebody change our practice, we might use the COM-B, which Tina talked about, or we might use a couple other frameworks. So the theoretical domains framework maps well with the COM-B and can help you identify implementation strategies. Or Marjorie mentioned for FI block, they use the consolidated framework for implementation research, the CFIR. That's a framework that can also help you identify implementation strategies. And that framework also has quite a few associated tools that the developers of the CFIR post on their website for developing things like interview guides and surveys to help you gather information about your why. So these are some of the frameworks we like to use. You can see we've identified frameworks and resources for many of the steps throughout the cycle. And so those are things that you can reach for and that the workbook can help you find. We can go to the next slide. Yeah, so one of the resources that we've included in this workbook is something called the Select tool. And so this is a tool that helps you take your barriers and you map them to that TDF I was speaking about. So that TDF has different domains related to behavior. So we can take a barrier and we can say, what TDF domain does this barrier describe? So if we're thinking about Tina's moves example, somebody said, it's not my job to move patients. That's what physiotherapists do. We can look at the TDF and say, okay, that barrier probably belongs to the domain of social professional role. So they don't feel it's part of their role to do this thing. And then when we've mapped things to the TDF domain through through the combi and something called the behavior change wheel, we can map those barriers to what we call intervention functions. So those are categories of implementation strategies. So we know, for example, you can see here that social professional role and identity maps well to implementation strategies under education, persuasion, and modeling functions. And then if we go to the next slide, you might have to click a couple times. Yeah, this is the second part of the select tool. So once we've identified what intervention functions might be useful, we can then pick what implementation strategies might work well. So we knew that for addressing our barrier of it's not my job to move patients, education could be a useful intervention function. And then when we look at this table, we can see we have a couple of options for what might work best for education for implementation strategies. So we could conduct educational meetings, or we could distribute educational materials. So we've been able to tell what might work best, and now we have a list of strategies that we can pick from this tool to help us with our implementation. We go to the next slide. So then we have other tools that we can use to help us prioritize and pick which strategies we might decide to move forward with. So a couple things that we like to think about first before we even jump into these tools, and Marjorie was kind of speaking to some of that earlier, is what strategies are going to address a really large number of our barriers. So like Marjorie said, one of the very first things they did was make sure that they had a process together for the clinical environment. So that addressed 10 of their barriers, which was the most of any of the other strategies that were potentially useful. So that was a good one to prioritize to do first because it was going to address a lot of barriers. And then the other thing we always look at is, are there any barriers that we need to address? Because if we don't address this barrier, nothing is going to change. So for example, say we had a barrier that was that we don't have access to the supplies to do this practice. So even if we have another barrier that's, oh, we don't really know how to do it, it's not really going to matter if we spend a lot of time educating and training people because we didn't give them access to the materials, so they're not going to be able to do the practice. So we'll also look and make sure we've addressed any of those barriers. So we call them hard stop barriers, that no matter what else we do, we're going to prevent people from being able to do the practice if we don't address that. But once we've looked at those two things, we might still say, okay, we still have a lot of options for implementation strategies, and we're not really sure, which one should we decide to address. And so we want to work with our knowledge users. So it might be patients or clinicians, because they might help us pick which ones are going to work best. But then we can also use these criteria. They're called the APPEASE criteria. So we want to look at, is the strategy going to be affordable do we have enough money to make it happen, enough resources to make it happen? Is it going to be practical, or is it going to be really difficult to do in your setting? Is it going to be effective when we're looking at what our options are? Which of our strategies have the most evidence to say this is going to be highly effective? For example, we know like printed material education can work, but its effect size is maybe only 2 to 3% versus some other strategies have a much larger effect size. So we might want to consider some of those more effective ones first. Is the strategy going to be acceptable for our population? Maybe your population really hates printed educational materials. Oh, sorry, I lost my lights. There we go. So if you give them printed educational materials, it's not going to be acceptable to a population and they're not going to use it. Then you want to consider, are there any side effects or safety concerns with your strategy? And are there any equity considerations that you want to make in helping you pick which strategies? So I really like these criteria for helping you with that prioritization process. And of course, you're going to want to look to your knowledge users and partners as well to help you pick which strategies are going to be best for your population. And last tool that I'm going to make a plug for today, one of the important things, I think Tina's touched on it, Marjorie's touched on it, it's also important to consider intersectionality in all of your implementation work. So that's considering both in your population, what intersectional factors might exist that could affect implementation, but also on your implementation team, what intersectional factors does your team have that might affect the work that you're doing as well. And our team here at the Knowledge Translation Program has developed a number of resources to help you consider intersectionality as a part of your projects. We go to the next slide. We have a few workbooks that we're going to include in that resource package that we're going to send along. But this is one of them. So this is our reflection workbook. So this takes you through thinking through intersectionality as a part of an implementation project and helps you as an implementer, an implementation team, reflect on intersectionality and how your intersectional factors could impact your project, and also how you can think about intersectionality of your populations. And then there's also a number of other workbooks that help you think through intersectionality at like particular steps in that action cycle as well. And we've included those in the resource package that we're going to send along. Next slide. Great. And last slide, I'll just say, when people are thinking about developing their implementation teams, you don't want an implementation team to be too big. The bigger it is, the harder it is to get things done sometimes. But generally, we say implementation teams should be about 3 to 5 people. And between those people, you want to look for people that have some of these specific things that I put here on the slide. So you want to look for somebody that knows the clinical intervention you're trying to put in, and somebody that knows the KT intervention that can help you promote those core components. You want somebody who knows and can apply implementation science methods to your project. You want to look for people that can help promote and participate in systems change. They can work at multiple levels of the system. That's an awesome person to have. And you want somebody who knows about and can apply monitoring and evaluation things, can help use data to determine how things are going and what you might need to adjust. And so you might have somebody that has multiple of these things. You're probably not going to find all of this in one person. Maybe you will, but it's most likely not. But if you can find a few people with a few of these different things, that can put together a really strong implementation team for you. Right, and the next slide. I'll just make a quick plug here as well. If you're interested in learning more about some of these topics, we do offer a couple of courses that go kind of deeper into some of these topics. So we offer a Foundations of Knowledge Translation course online. This gives you some of the basics of knowledge translation, like KT definitions, some of those main theories, models, and frameworks that get used. And this one is online, you can take anytime. And on the next slide, we also offer a course, we call it the Practicing Knowledge Translation course. It's 4 or 5 days, and it goes into detail about all of the things we talked about today. It gives you a lot more examples and hands-on practice. And the idea of the course is at the end of the course, people have come in with a project that they want to implement, and they walk away with a action plan that they can use to go out and start implementing. And so if you're interested in either of these, I know the slides are going to get passed along. So there's a QR code there that you can use to go to our website to get more information about the courses that we offer. Great, then maybe I'll hand it back to Tina to kind of round us out.
Thanks so much, Jeanette. Okay, fantastic. So just to summarize, so when we're implementing, we really want to start with a strong evidence base, and we would like to use theoretically rooted frameworks to identify all the different barriers and facilitators that may exist, and then to match those to the appropriate strategies. And when picking our strategies, again, there's an art and a science to it. So we want to look to theory, look to evidence, but also really work with our knowledge users to consider that appease criteria, to consider applicability, sustainability upfront. And we really want to involve knowledge users as project partners throughout the research cycle, including the process of developing the intervention and implementing it. And along the way, we really want to consider intersectionality and equity. And then finally, we want to evaluate everything to unpack the black box of implementation so that if our program works, we have a blueprint of like, here's what we did, here's what you could do in your own setting, here's how you can scale it up. And if it didn't work, well, here's what we did again. So maybe you could try something different or test another strategy. And again, we're contributing to this collective knowledge, not just about the specific practice, but about the implementation methods. So I'll speak on behalf of our team to say, you know, we're more than happy to take questions today, but also after this session. We love speaking to these tools and methods, and happy to kind of jump on a call and talk through any kind of specific projects or questions that you may have.
That's great. Thanks so much, Tina, Marjorie, Jeanette. It was really fantastic, and you're getting a lot of kudos and thanks in the chat as well. And I'm going to come back to a couple of questions here. I want to also thank some of the people participating. Carrie Schubert Mackey has also popped in a few links from the Center for Implementation Science, which is another resource that has very high quality. And Carrie actually has a couple of questions, and I think I'll pick out two of them. She's definitely on top of this. One of them is around the differences between implementation science and just change management.
Yeah, that's a fantastic question. I actually had a slide said, what's the difference between KTQI and patient safety, but I took it out for time. So I'll start by saying these are distinct fields, but they share so many commonalities. And what I presented today is coming from this lens of KT implementation science, but you could absolutely apply these steps of thinking about evidence, working with knowledge users, and implementing in a QI setting, in a patient safety initiative. I think the key feature of implementation science, and specifically the term knowledge translation in Canada, is really centered in this idea of using evidence, and specifically using novel evidence to drive practice change. So I think one of the key features of KT is there's a specific evidence-based practice. There's something that the literature is saying we should be doing that's actually not being implemented. But recognizing that as we do implementation, and if we can scroll back to the KTA cycle, I could maybe point to it, but as we're doing implementation, we're actually embedding these principles of QI throughout the project. So in the cycle, we have this step here of assess barriers and facilitators, select knowledge, monitor knowledge use. Well, that's exactly what a PDA cycle is, right? And so I think the key thing is that it's iterative. And so even though implementation, the feature is implementing a new practice, that's not to say along the way we don't want to also improve our quality improvement strategies of making things more efficient, making them less costly, making them more safe. They all kind of go hand in hand. And I would say, you know, I would use these methods to whatever is helpful for your own work, and get less stuck on, is this QI patient safety implementation? These are really kind of generalizable methods, but that's really where they came from, is they originated from different disciplines with the kind of the science and the evidence of an innovation or a new practice being the key feature of KT.
Yeah, thank you very much. And it's something, you know, even in the context of the entire learning health system, we get this, you know, why was this not just QI, right? And it's like there certainly there is, I think, parallels and to be part of it for sure. And yes, I know you could run days of workshops on this material. You guys have so much, and I really appreciate how hard it was to get this down to something we could fit into today. I think when John Lavis was running the learning health system bit at the very beginning, he said, in an hour, so we're going to take our Pico course and turn it into a nano course.
Yeah.
It was already very small. So I appreciate your talk suggestions here for us. I think a little bit on future webinars being on spread and scale. I think that's another great idea. If people have suggestions or other questions here today, and I've learned a lot today. I wonder if you or Marjorie or Jeanette had any commentary around this notion of champions. And maybe even in, you know, to put it in the contrast way, a change agent versus a clinical champion or a champion. I've heard of both of these kinds of expressions, and I'm never quite sure how do I know what's what and who does what.
Yeah, great question. Maybe I'll turn it over to Marjorie, because I know you used it in your own practice, and then I can maybe speak to the literature. But yeah, go ahead, Marjorie.
Yeah, you know, a champion, being a champion, I think that's part of my daily role, is actually modeling best practice and reinforcing For us, as an example of the hip fracture, uh, uh, you know, quality standard, whether I'm in the emergency department, the first thing, if they see me, because I'm down there usually first thing in the morning, if one of our patients is down there, as I said, we get it automatically, a referral about them, is to ask and reinforce with the nurse that's caring for that patient. Have you heard from acute pain service yet? To cue them and champion, that as a reminder. So our champions we need to build and reinforce and empower those at every stage of the game. On the units, when I go up to a unit to see a patient that might have been transferred up there, again, is to speak directly with the nurse and say, oh, gee, have you heard from the acute pain service yet? And reinforce. And if they say no, and then there's an opportunity again to reinforce the expectations and around providing fascial iliac block to patients. So everybody becomes a champion once you've modeled that behavior, and we can take advantage of that. Just making sure that key champion is present, and to reinforce and build those local champions all the way.
Thanks, Marjorie, and completely agree. And maybe I'll add one other thing is there's a lot of literature, and I think champions can be defined in a couple of of ways. We see things like, champions, opinion leaders, train the
Yeah.
trainer approaches, which are similar but again distinct concepts. And so you could have people who might not be kind of the people on the floor who are rooting for the intervention and supporting the day-to-day uptake, but they might be very well respected. And so having their buy-in goes a long way even if they're not kind of the front facing people doing the legwork. And so you may want to consider kind of a couple of different combinations of people, the opinion leaders, the people on the ground as champions. And I will say again, looking to the implementation science literature here is really key. There's Cochrane reviews, there's different systematic reviews that talk about what's the most effective way to train a champion? How do you even identify who an opinion leader is? So there's a wealth of literature out there that when we get to the step of picking our strategy, we can make sure that it's as effective as possible by looking to those resources.
Mhm.
Yeah, that's amazing. And certainly the flavor, and I hope all the participants today are also getting this flavor, and everybody would like to have this team on their team, I'm sure, to help support their work. But the notion and the use and the application of evidence is strong. And so I often suggest, well, one of the things we're really trying to emphasize within this learning health system framework is at every stage, the use of evidence. Like there's a whole evidence piece that's usually around the intervention, but just thinking about how do we use data? How do we do implementation? How do we do evaluation? That we should be thinking about best practices and evidence-based work throughout, and co-design as well. So I hope the participants here have gotten that flavor. And if you've missed some of those past ones, do feel free to go back and catch them. I'm going to just prompt one more time for additional questions for our speakers today. I'm going to come back to Carrie made a point here. Can we advocate for a learning health system accreditation for OHTs? I have this sticky on my laptop, and it just says, and I don't know when I wrote it, when every OHT has a learning health system champion. That doesn't have a full phrase around it, just says that. And I don't know if that's my retirement plan or if it's anything, but I'm a strong advocate. And I'll just highlight that in a couple, I don't know if we'll get to it in November. It might have to be put off to a little bit until January, just in terms of how much we can fit into one of these events. But if you go to the community of practice, you'll get a little bit of a preview this month from Dr. Victor Rentes, who has developed a maturity framework and assessment so that we can at least start with a little bit of an assessment of where Ontario health teams are at, or other organizations. It's not designed specifically for Ontario health teams, but we've been designing in the background a bit of an audit feedback tool on how are you doing in terms of implementing a learning health system, which also includes elements as they relate to implementation science. I am still looking to see if there's any additional questions. There's a suggestion for a future webinar, and perhaps, oh, I see Patrick, the next webinar, Kaylee, I think somebody has a link at the beginning. Can they pop that link back in this chat? Because there was a registration link at the very beginning that Kaylee spoke to about the community of practice and how to get there. Yes. So this one here, October 8th, assessing learning health system capabilities, a self-assessment tool. There's a link there. And we can post it back into the chat. I can do that here, I think. I don't know if I can or not. I don't think I can. Oh, there, somebody's popped it back in. Thank you again to our speakers so much for coming today. And Lale, I'm going to ask, I don't know whether you can quickly fire all the way back through the slides to the end. We do have an opportunity for people, particularly today, to, if you go to the QR code, we have this HSPN webinar series the fourth Tuesday of every month. Every month we're here on the fourth Tuesday from 12 to 1:30. Except August and December. And we have, as Tina had alluded to, in the next one, which November, will be our evaluation one, which will round out the gears, and then we have some more work to do. I think if you've looked at the framework on the accelerants and brakes, key enablers. We have a very short, it's a 3-item little piece of feedback. And most importantly, then there's a 4th item that is a little bit of an open text space for you to be able to suggest additional topics. We have 2 more in this series coming up for the learning health system. If you've been with us for a long time, you'll know that previous to that, we had done one in some of our evaluation work, but the previous series was around the quintuple aim. And then we had a series on equity. So we really like doing these in series, and we find we get the best benefit if we could do it along those lines. Olivia has a question about it being public. Yes, and I can just pop that link back in the chat again. But if you go to our HSPN website and follow the links to Ontario Health Teams, you will find all of our past webinars. As I said, going all the way back to December 2019, we've been at this for a little bit of time. And really appreciate everyone's participation. Like, just huge thanks. You took some really, so much evidence and literature brought into some very practical tools today. And I learned so much, and I'm quite sure looking at the chats, awesome. People are really, really pleased about all of the learning that they had today. So I think, amplifying the impact, particularly around implementation science, is so valuable. We're also putting out an email blast today about the upcoming conference on the North American Conference on Integrated Care that's happening in Calgary. I see that we have some people from West today joining us, and I know some people participating. On the next slide, it shows that just a flag for that conference. And I don't think the early bird, I think I pulled this in from a previous webinar. I don't think that early bird pricing is still there, but it is still happening. The program is out. The keynotes are out. The panels, just absolutely wonderful learning experience for everybody if you have the opportunity to be there in Calgary. And that closes us out for today. I'm so happy that everybody was able to join us. Thank you. I don't have it in as many languages as Tina had up on her slide just a moment ago, but very much thank you to the team and to our presenters today. It's been a lovely pleasure, and I hope everybody has a wonderful afternoon.
Thank you so much. Bye, everyone. Thank you.
Thanks for having us.
Everybody.